Good morning, dear colleagues. It's a great pleasure to introduce Philip Müller. He is a fifth-year resident in our department, and he spent 3 years in Heidelberg doing quite a lot of research, and then he joined our team for the last 2 years. I'm happy and I'm looking forward to hear more about rectal cancer. Thank you very much for your attention.
So good morning, everybody. The next few minutes we will spend on rectal cancer, its epidemiology, the preoperative workup, the treatment, possible surgical complications, and in the end I will provide you with a take-home message. So I think you all know that colorectal cancer is quite important and quite common. Just to relate to Switzerland, we have about 4,000 cases of colorectal cancer in Switzerland each year. Even though colorectal cancer is quite common, there's a decrease in the incidence, probably due to the screening colonoscopy, and a decrease in mortality since the last few years due to an improvement of the oncologic treatment. So I think the risk factors are quite known. It's age, obesity, a Western diet, smoking, and some more. So if we look at the time when colorectal cancer occurs, it starts at 50, and there we start with the colonoscopy and goes up from there. However, there is a quite dangerous trend that colorectal cancer in the older population decreases. However, in the younger people below 50, there's an increase, and I think nobody really knows why that's the case. So today we're not talking about the 60% of colon cancer, but about the 40% of rectal cancer. Now I would like to ask the residents, what's the preoperative workup for a rectal cancer patient?
MRI?
Yes, that's one thing.
Colonoscopy?
Also true. Anyone else?
CT abdomen and lungs, and tumor markers.
Perfect. So I think you mentioned a lot of things. First of all, we have the clinical examination with the digital rectal examination, then the tumor marker, that's important for the monitoring of the recurrence, a full colonoscopy to rule out the second carcinoma in the colon, the rigid endoscopy for the assessment or for the classification of the rectal cancer. What we don't do that often in Zurich is the endosonography, but we do the MRI for the local staging and the thoracic and abdominal CT to rule out distant metastasis. So when we classify the rectal cancer, we have lower, middle, and upper rectum. That's defined by anal verge to 6 centimeters, 6 to 12, and 12 to 16 centimeters, and it has to be evaluated in the rigid rectoscopy. As I told you before, the MRI is for the local staging to see how the tumor grows, how many lymph nodes are involved, and what's also very important to see in every radiological report is the CRM, the circumferential resection margin. That's the distance between the tumor and the mesorectal fascia. When we look at local recurrence rates, which were pretty high in this study here, that you can still see that there's a big difference between upper rectum and middle and lower rectum. That's why the upper rectum is treated like colon cancer with an upfront resection. However, in the middle and lower rectum, we have to evaluate if the patient needs a neoadjuvant therapy. So a neoadjuvant therapy is needed if the patient has a T3 or T4 tumor and if the tumor is nodal positive. If we look at when the chemotherapy should be given, there was a study published in the New England Journal of Medicine where they evaluated if the patient should get neoadjuvant or adjuvant chemotherapy. And the chemotherapy has an effect on the local recurrence rate. And as you can see, the preoperative chemoradiotherapy bisectioned the local recurrence rate in this trial. And furthermore, it led to a lower morbidity with an equal mortality. And now we come to the surgical concept. A low anterior resection, we do a total or partial mesorectal excision. I will talk about that in a second. Then we also have to take all the lymph nodes along the inferior mesenteric artery, and we have to take out the tumor with some safety margins. So in the upper rectum, we need a safety margin of 5 centimeters, which is equal to a colon cancer. In the middle and low rectum, with a good grading of the tumor, we just need 1 to 2 centimeters. And in the new S3 guidelines from Germany, in the low rectal cancer after neoadjuvant therapy and the negative frozen section, even 0.5 centimeters are adequate. So as other surgical techniques, colorectal surgery has also evolved from an open approach to a laparoscopic approach to a robotic-assisted approach, which is mainly used in the University Hospital of Zurich. I'd like to show you a video of the TME preparation in the pelvis. So robotic surgery has all the benefits of minimally invasive surgery, which means smaller incisions, faster recovery, less wound infections, and less morbidity, lower rate of incisional hernias. And as you can see, a very precise operation is possible with the Da Vinci system. The surgeon has a 3D vision. He has 7 degrees of freedom, and I think a more stable camera than any of us residents can provide. So there's more and more data in the literature on the treatment with the robot. However, I think we're not there yet. So there is data on the oncologic outcome, on the functional outcome, on the perioperative outcome. I just picked 2 studies that were published in Annals of Surgery, and they showed that there's a lower conversion rate. It takes a bit longer. However, I was astonished that it's only 40 minutes with the robot. The positivity rate of the CRM was not different. The perioperative morbidity is similar, and there's evidence of a lower rate of nerve injuries after robotic surgery. Now I come to the concept of mesorectal excision. Before the concept of the mesorectal excision, there was a high rate of positive resection margins because the surgeons just cut out the tumor and the bowel, and that was it. And when the resection margins were positive, there was almost every time a local recurrence. And then came Billy Heald. He introduced the concept of the mesorectal excision, which means we do not only take out the tumor just like that, but that we respect his holy plane, which is the mesorectal fascia, and that we also take out the fat around the rectum, the mesorectal fat. He published that in 1982. Just another picture to show what is done, or what is meant by mesorectal excision, is that we take out the mesorectum with the tumor between the mesorectum and the presacral fascia, and many studies have shown that this leads to a reduced local recurrence rate. So the quality of the TME can also be graded and is assessed by the pathologist. Here you can see a nice TME, a complete, a near complete, and the incomplete, and I think it's not that surprising that those are a bad prognostic factor for local recurrences, and it's also used as a composite endpoint in a lot of clinical studies. So after we have taken out the cancer, we also have to reconstruct. In Zurich, we are mainly doing an end-to-end anastomosis with a circular staple. One could also do an end-to-side anastomosis, or the more time-consuming and more complex J-pouch and transverse coloplasty. They may have a better functional outcome. However, we perform the end-to-end anastomosis. If a negative distal margin cannot be achieved with sparing of the sphincter, we have to do an abdominal perineal resection, which means that we also take out the anus, and we have to perform permanent colostomy. And this here is the specimen, how it looks like with resection of the anus. So now one question to the residents. What are typical post-operative complications after rectal surgery?
Paralytic ileus.
Yes.
Bleeding, infection.
And more surgery-specific complications?
An insufficiency of the anastomosis.
Perfect. So the short-term complications are anastomotic leakage. However, we always or almost always put a protective loop ileostomy. That's why most patients are not symptomatic. However, it's a very common complication, and the anastomosis is at high risk. Then I was a bit surprised that it's 5% of hemorrhage, anastomotic hemorrhage. We don't see that often here in Zurich. And then in the long term, we have the anastomotic stenosis, and after nerve injury, a mild incontinence occurs in many patients, and there's the risk for urinary dysfunction and sexual dysfunction as well that the patient has to know about. So I already come up with the take-home message. I think it's very important to know the different treatment strategies according to the preoperative staging. I hope that I could show you that it's not just the surgeon that treats the patient, then it's a interdisciplinary multimodal therapy. We in Zurich almost always perform a minimally invasive approach, especially with the robot, and therefore it needs specialized high-volume centers. So I hope you liked it, and I'm happy to answer your questions.
Thank you very much. Very nice illustration, to the point. So I really enjoyed this presentation very much. Maybe just 3 questions or comments. Number one, I think it's clear today that the robot is no longer just a marketing tool to attract patients anywhere, but there are some advantages. So maybe tell us what are the data now clearly on the advantages. You list some of them, which are pretty obvious. Maybe we'll love to have a comment specifically for rectal surgery. Next point, which is a hot topic in this country, I think is heavily discussed now, is who should do this. As a patient, if I need the surgery, I know a little bit where I would like to go to get the expertise, etc. Maybe I would like to have a comment with the minimal number, and among the many centralization, pancreas, esophagus, etc. This is probably the one that most of surgeons would like to keep. We speak about the deep rectum, and we have seen here that it's not just doing it, but quality of the surgery has a strong impact on long-term outcomes. So we'd like to have a comment from the academic side about where, without politics, where we should really go in this country to do that. And maybe just a more specific question about the protective ileostomy. We do it just, as a culture, or is this really strong data that we should do it? I know that not everybody is doing this for this kind of surgery, so when it works, of course, it's an advantage, patient is happy, but maybe to tell us here also about the data, when we should do it, or is that just routine, and which situation we may not do it? I don't know.
The question regarding the robot, there's an ongoing discussion, but there's emerging evidence now about the robot. And what we know from the large randomized trials that we have, and there's only 2, is that oncologic superiority is not given with the robot so far. However, these studies were done with surgeons that have not undergone strict training on the robot, And secondly, most of these operations were performed using the older robotic system, and that makes a big difference. So in surgeons that are specifically trained using the most modern generation of surgical robots, these data would look much different, but unfortunately we don't have them. There is, however, more and more evidence that the functional superiority is actually given using a robot, and there's a number of studies now that report better outcomes when it comes to bladder and sexual dysfunction postoperatively. In some of the studies, actually, the rates are about 50% of that seen in laparoscopic surgery, and that is credible to me. Second question regarding minimal numbers. Switzerland has set a minimal number of 10 operations per center. The canton of Zurich has a minimal number of 12 per center. However, these numbers only refer to low rectal resections. Our personal feel is that these operations should be done by surgeons who do more than 10, and ideally not only focused on the number of cancer surgeries, but of rectal resections as a whole. And we believe that a center should be performing about 30 to 50 rectal resections a year in order to be competent in this type of surgery.
Concerning the ileostomy, we routinely perform the ileostomy if we perform a low anterior resection. So everything above we do not routinely divert. There has been clear data that major complications can be prevented with the ileostomy. Not so much the insufficiency itself, but the complications resulting from such an insufficiency. We can keep the anastomosis in a lot of cases. We can do a local treatment. Today, endosponge is a hot topic, and with this, we can keep a lot of anastomosis even though they are leaking a little bit. So that's clear a benefit in low anastomosis. Maybe one comment on the radiotherapy I would like to add. You wanted to mention that as well, that we have two different decisions to take, either the long-term or the short-term radiotherapy. Either we can do a short term with 5 times 5 gray without chemotherapy, followed by immediate surgery. And the long-term treatment is usually 28 days, 1.8 gray, resulting in 50.4 gray in total. That's combined with a chemotherapy. The decision has to be done on an individual basis. Concerning local recurrence, they are more or less equal. However, if we need a downsizing of the tumor, especially if it's close to the sphincter, then the long-term radiochemotherapy should be preferred. That's just a comment on that. Are there other questions?
Thank you. Just maybe on that point you were just mentioning, I think the downsizing is because they also wait, right? After the radiochemotherapy, there's a time span that is weighted. So would that not also be an option to do the short and then wait? Only the short radiotherapy?
Yes, thank you very much. Yes, in the long term, we typically wait between 6 and 12 weeks. That has been shorter. Now, today, there are more and more data that we should wait longer, 8 to 12 weeks. We usually plan the operation in that range. And in the short-term therapy, the recommendation is clearly that the surgery should be followed just after the radiation, usually about the week after. There's no benefit of waiting too much.
There's actually no real downstaging that occurs after short-term radiotherapy. Short-term radiotherapy really serves to lower the local recurrence rate and not downstage a tumor. Maybe just a quick comment about diverting ileostomies. We use a diverting ileostomy as a routine in patients with an oncologic resection who have an anastomosis at or below the peritoneal reflection, and that is the current recommendation by most high-volume centers. If you do an anastomosis below the peritoneal reflection in somebody who's had chemoradiation before, you should have a very good reason not to divert. And then that is okay for the mid-rectal anastomosis. However, in low rectal anastomosis, it's generally recommended to divert in case of oncologic resections. Another just brief comment about the resection strategy. It's a detail, but mid-rectal cancers are treated by what operation? By TME. So if you have a tumor in the mid-rectum, although 1 to 2 centimeters may be enough, the recommendation is to do a TME. And only in low rectal cancers, the closer you get to the sphincter, 1 to 2 centimeters or even below 1 centimeter can be an option, but you need to be very careful. You need to have frozen section specimen intraoperatively, and also not in G3 tumors, only G1 and G2, but not in G3 tumors. Again, very nice presentation. Thank you very much.